Hello, everyone. Welcome to the webinar, NIH Centers for AIDS Research Network of Integrated Clinical Systems. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. Today's program is the third in a series of 5 webinars on HIV and aging, data access, availability, and research funding opportunities. For information about this webinar series, go to geron.org/webinars. A question and answer session will immediately follow the live presentation. We will be accepting questions through the questions feature accessible on the GoToWebinar panel. Also located there are downloadable handouts for today, a copy of the presentation slides. Today's presentation will be given by Dr. Michael Saag, CNICS Principal Investigator, Professor of Medicine, Director of CFAR at University of Alabama, Birmingham. Thank you, Dr. Saag, for bringing us this important program.
Well, thank you so much.
Without further delay.
Yeah, thank you so much for having me. Yes, and so this is the CFAR Network of Integrated Clinical Systems. You could call it CNICS, or we just affectionately call it CNICS. Next slide. CNICS consists of 8 CFAR cohort sites, and you can see them on this slide. They're geographically dispersed across the United States. UAB in Birmingham, where I exist, I'm the PI, and it's the National Administrative Hub for CNICS. University of Washington, led by Dr. Mari Kitahara and Dr. Heidi Crane at University of Washington. They are the data management core. There's expertise at every one of these sites, both epidemiologic, clinical, social behavioral, and we take full advantage of that. And as you look around the sites, you can also see that not only are they representing different geographic regions of the country, they also have with each site a distinct demographic of the patients that are seen there, and that gives a lot of richness and robustness to any analysis that we do. I'll start with the next slide, describing exactly what this is, and the numbers on this slide have been updated, so you'll see that on future slides. But basically, CNICS is an R24 platform. What does that mean? It means that it's a resource that's designed to support research that anybody in the world would like to do. So ordinarily, you think of some of the cohorts as mostly doing work within their own groups, so that in our case, it would be the 8 sites. And certainly, there are investigators at each of our sites who access CNICS data and use it. But the real purpose, the primary purpose, is to get these rich data sets in the hands of investigators throughout the United States or worldwide, so that you can use the data for your purposes. And in fact, the second aim of our grant is to enable research by investigators to address questions that are important to them, share the data set, share specimens, share expertise when needed. And a key part, as you'll hear throughout the presentation, is also mentoring. And that mentoring can be for younger investigators, but anyone really who's not familiar with CNICS might need some mentoring, if you will, on just how to get to the site and how to use the data, what is feasible within CNICS data and what's not. So my open invitation to everyone listening today is learn about CNICS, and please reach out to us with your ideas, a concept proposal, and we'll go through and review it for you. And we will, our goal, unlike most study sections or things, our goal is to get to yes. We want as many people as possible using this resource, and you'll see some of the success that we've had in that over the years. We were first funded around 2005, 2006. We're now in our 3rd grant fund cycle, and we're about ready to submit for another round of competitive renewal. Next slide. The open access database, as I've just said, this is meant for everyone. 32%, or about a third, are from outside of CNICS. I'd like to see that number more at 50 or 60%. So again, the more the better as far as I'm concerned. Alvaro Munoz, who started the MAX cohort that you've already heard about, once had a great line. He said, data are very promiscuous. They'll go anywhere with anybody and do anything. So there's no cost in terms of accessing the data or using the data. The cost really is your time. And our job is to get you the data sets that you need to answer the clinical questions and other research questions that you might have. The mentoring program is really state of the art. We do a lot of one-on-one assistance. It's not that we take on mentorship as an institution would, but for a lot of times we could be a co-mentor on a K award, or we might simply just be consultants to younger investigators, especially as they access the CNICS platform. 59% of our approved concept proposals are led by people at the early associate, but mostly assistant professor level, or their trainees. We're very, very excited about that. 57% of our studies are led by women, 7.5% by underrepresented minorities, and of course, we'd like to increase that. So please, if you have investigators who want to participate, strongly encourage you to do that, and I'll give you data, or I'll give you information on how to access us as we go through. One of the things that we have at our data management core are rigorous standards for quality control, and I think a lot of you listening have probably had experience with EMR data. And it doesn't take long for anyone who's trying to do research with EMR data to realize that those data really are too disparate and actually inaccurate to do research quality investigations. What do I mean by that? I look at data as three buckets, three different categories. Administrative data, which basically is who is this person and did they access the system and what's their insurance status and contact information. That type of data is usually accurate and accessible, and you don't really use it for much except just to anchor a query. Clinical data, clinical quality data, are those that are used for routine care. And for the most part, obviously works for routine care, but when you think about it, when you look through the data carefully, there's an awful lot of errors in those data. So much so that you really can't easily do research with them. So the third level of data is what I call research quality data, and that's what we generate as a matter of course with CNICS. So part of what our grant pays for is for each site to have data managers and data quality assurance investigators, researchers who do nothing but update, QA, harmonize, and then link things to our well-defined data dictionary for which we understand what the terms mean and go from there. Another thing we've done that I think has been pretty innovative is we adjudicate outcomes, and I'll give you a quick example of that. Myocardial infarctions were seen, of course, in people with HIV. So we wanted to see how accurate those data were. Now you'd think that data coming from a health record would be pretty accurate, right? That if a heart attack is listed as a problem on the problem list, you would expect that that is an event that actually happened. So we decided to test that because we really wanted to do a strong outcome study. And we had all the sites go to the primary hospital record. Most of our data is outpatient, but we do have access to inpatient data. It's just not part of our usual data set. And we pulled the records, de-identified them, sent the de-identified chart information to 3 blinded cardiologists who then adjudicated and said, this is a heart attack for sure, this is probably one, and this is not. And too much to our surprise, and my surprise, up to 40% were not really heart attacks. And what was more, the beauty of also doing that is that we're able to break it down into type 1 versus type 2 myocardial infarction. And once that was done, we've consistently done that ever since, so that if you're looking to do work in cardiovascular disease, we have adjudicated data for myocardial infarction, pulmonary thromboembolism. We're working on it for stroke. We have that pretty much worked out now. We also have adjudicated data emerging in atrial fibrillation and congestive heart failure and COPD. So there's a lot that we're doing. It's a work in progress, but the cool thing is that every time we take on one of those adjudication projects, those data are pristine and they remain there. So anybody coming along after that point would have access to these adjudicated data. Next slide. Over the years, we've gained impact in terms of research. Right now, our total grant funding has exceeded $124 million, 108 different funded awards in the forms of pretty much everything the NIH offers. And there's been a few non-NIH grants. There have been a total of 364 papers in peer-reviewed journals. And this is the coolest thing, I think, is that when you look at the number of patients in our study, and that's now about 37,000, and you divide the cost per patient, we cost less now than $80 per patient annually to do everything that we do. And the delivery of data is at no cost to the investigator. The delivery of specimens is free except for shipping costs. So all this is available to you. You've just got to reach out and let us know. I'm very proud of this, the graphic that's on this slide that talks about our publications, but maybe more importantly, our citation index, which has really increased dramatically over the last several years during this grant cycle. And I think it's a testimony to, first off, all the investigators who have worked with CNICS, but it's also a testimony to the quality of the data, how it can be used by so many people, and in a very effective way and in a way that has meaning in terms of impact on the field. Next slide. Similarly, I've already alluded to total grant funding, and this slide on funding is a little bit complicated, but let me just kind of walk you through it. For each year along the y-axis there, you can see that there is a pair of bars. The bar on the left of the pair of bars is basically the type of award that's been given. So you can see that a lot of the awards are R01 or K training. And then the bar that's just adjacent to it is early investigators versus senior investigators. So you can see throughout that the early investigators are the predominant users as principal investigators seeking CNICS, and that's really by design. We love that. We want to work with as many younger people, ideally, of course, with a senior mentor at their site who's guiding them, but this gives folks a way to really engage quickly, not have to go through the pain and sorrow of trying to pull together their own data set. These are adjudicated data, they're clean, they're readily accessible, and they're provided free to the investigator. Of course, we're not going to be able to pay for the analysis or the work of creating the reports from the analysis, but we will provide the data, and we will give a free advice in terms of how best to use the data, and we also will give information to folks about where the limitations of the data are. A lot of times people want to do something and they send in a concept proposal, and in the course of that review, there's two things. One is a science, and it's not meant to be critical and say your ideas are bad. Rather, it's to say, wow, that's a really good idea. Maybe you could also look at it this way. So it's a free consultation as part of the review. And again, we try to get to yes. The second part of the review is feasibility. Most often the data exists, but as all of you know who have worked with research data, not every data element is as strong as another. So we carefully look through and see, okay, the data that we know exists in CNICS, we know the quality of each data element. Will that allow this particular proposal to be successful? And if the answer is yes, then we're off and running. And if the answer is no, then we try to work with the investigator to modify. Sometimes R01s have been submitted, for example, like the adjudication for myocardial infarction, to really make the data pristine enough that we could use for the studies that actually were done from that. And finally on this slide, the little blue boxes, that you see scattered around, that's basically the amount of funding. And if you look at the, whatever that would be, the y-axis on the right side, that tells you the number of dollars in millions per year. And those are new grants. That's not continuing on. That's the amount of funding. Each one of these is the new awards each year, not the total awards. So this is like an incidence of awards rather than a prevalence of awards. Next slide. This has led to a lot of high profile publications. I don't want to go through these obviously in detail, but I think you can just scan your eye across them. This is really meant for the handout as much as anything. But you can see high profile journals here, the JAMA Cardiology, Annals of Internal Medicine, JAMA Psychiatry. And as you'll see in a second, we have perhaps the only cohort in the world that links clinical data to patient-reported outcomes to specimens. And with that, you can triangulate analyses, and you get a lot of really remarkable potential in terms of what can be done. And the cool thing for me is that it gets better and better every year. But the coolest thing for me is participating in an enterprise whose mission is to get to yes. And that is so nice. I really love that about CNICS. Next slide. The methodology is really about that this is an ongoing clinical cohort. So what that means is that we're taking patients who are coming into any of these 8 sites. We have over 98% participations. The patients allow us to use their data, and for certain data elements, they give specific informed consent. It's dynamic in the sense that all individuals, as they arrive for a condition, so there's not any selection bias per se. It is what it is for patients showing up. The EHR data is collected. It requires, as I mentioned, extensive review for verification and recoding prior to use in the research. When the data are submitted to the data management core at UW, it is scanned for lack of a better word, cleanliness and compliance with the standards for submission. And then there's an iterative process to clean up any errors. And then once those data are in the database like that, then it's relatively easy to just package it together to send out as a data set to investigators who have had an approved concept proposal. And it's all in the here and now. So you can look at the contemporary treatment era. And a lot of times we compare it to the era going back to 2000, the year 2000, and watch how things have changed. So that's really quite good. And the comorbid conditions in particular for this talk, we really are seeing our cohort age, and we can see a longitudinal progression, a lot of times with samples that have been collected at various time points along the way. So you can look at markers of inflammation, and then the emergence of disease over time as it might occur. And that ranges, as you see here, from cardiovascular, liver, renal, cancer, neurologic disease, and so forth. Next slide. So the data repository, if you could just focus on the figure, has a number of domains. And I'll just start at the top. So of course, demographic data, but we also now have geospatial data so that we can we can geocode where somebody lives. So you could even do epidemiologic assessments that can indirectly link to socioeconomic data. We have also drug resistance data. We have a paper in press right now that I'm very proud of. Took a lot of effort to get this, but drug resistance data as regimens failed, and asking the question, how many patients in today's world, when they have a failing regimen, have no choices or have limited treatment options? And as those of you familiar with HIV know, that and we compared this back in 2004, it was about 8% of the patient population when they had a regimen failure, you could not easily construct a regimen. And with our more recent era of treatment, that number is now down to about 0.7%. Also, we could look at the outcomes, and remarkably, even among those who had limited treatment options, we were able to see that their virologic outcome was virtually identical to those who did not have limited treatment options. So It's an underscoring of how well the providers did in terms of constructing a new regimen, but it's also about the potency of today's regimens. So that, I think, was a great use of CNICS data. We do have some limited information on healthcare utilization, but it's mostly around missed visits. I skipped over medications, but there are full medications of both antiretrovirals, but also every other medication. Have some difficulty with over-the-counter. I can't attest that we have those medications, but we do have any prescription medications, including opioids and other things. Healthcare utilization, as I was saying, basically, we have visit data, which I think is essential. We had a fascinating analysis about 10 years ago that associated race with mortality. And that didn't add up completely. So we started looking more carefully, and what we discovered was that also associated with mortality was missed visits. And then we did a marginal structure model analysis that showed that actually missed visits were the mediator of why the race association was there. And when you run the model with that as a mediator, race no longer was a significant factor. It was all about missed visits. And that was associated with about a 1.22 relative risk of mortality for each missed visit that a patient might have. And that meant they just didn't show. If they called and canceled, that didn't count as a missed visit. But you can see how you can use these data to inform not only clinical practice, but also healthcare policy. We have specimens, as I mentioned, but also genetics. We have at least 2.4 million SNPs that have been evaluated already. And again, this becomes cumulative. As we get it on individuals, those data stay and are available for others to use. The patient report outcomes I'll get into in a second, but I think that's the special sauce that CNICS has that any other cohort that I'm aware of does not. Laboratory, of course, all the key laboratory things. More diagnoses are adjudicated for the most part, and they're standardized. Mortality, we have vital status on everyone. We do not attempt, for reasons I can go into, to ascribe cause of death. We've tried that. It's extremely difficult. We can say what somebody died with, but it's really, really hard to say what somebody died from. And we've tried. We typically have just sort of waved our hands on that one. We could discuss that, but I think it's almost impossible to know for sure what somebody died from, except in certain circumstances. And so that's what we have as an overview of the data repository. Next slide. Our demographics, as I mentioned, we're now at 37,000 or so. You can see there's a nice mix of race and a risk factor for HIV. And as far as sex, male sex is predominant, but we do have about 22 or 23% females, and we have some transgender, and they're coded as such. So we know if they're cis or transgender. Next slide. This is probably the most important slide for this group. So this is kind of, I don't know what you want to call it, a wave figure. But what you're seeing across the bottom is, of course, the year, but you're also seeing color-coded proportion of patients during that year that are at a certain age. And so if you go to the far right side, you can see that we have now almost pushing 4% of our population is over the age of 70. And when you add to that those over the age of 60, you're now up to about 20%. And if you're over the age of 50, you're now looking at really more than 50% of our patients are over the age of 50. So we have, as you can tell from this in very graphic terms, that this is an aging cohort. And again, you have the ability, if you have questions that you want to have answered, formulate them, put them into a concept proposal, send them in. I would love to work more and more on aging questions. And we can talk more about that as we go. These are just brief reads of the data. I don't think we need to spend a lot of time, but you can tell that since the treatment era changed in 2008, 2009, the starting therapy above 500 CD4 count became the rule, but it also tells you that a lot of the patients who we are seeing come to us in a relatively healthy state at least in the last decade, with CD4 counts that were quite high for the most part. Next slide. We're also having, like most places, success with viral suppression. We're now at well over 80 to 85% of our cohort has suppressed virus, and that's continuing. So what we end up looking at with Scenics, and I think most of the cohorts you've been talking to, is what is the, I'll call it, natural history of HIV in the treatment era? How does this all play out as people start to live near normal lifespans? What happens in terms of incident comorbid conditions, be it myocardial infarction, stroke, pulmonary thromboembolism? I didn't mention that, but that's also adjudicated. Those types of things are now you're able to look at and define what this is. And as a rule, as most of you know, working in the field of gerontology with HIV, events tend to happen frame shifted to the left by about 8 to 10 years. So incident diseases for a lot of domains actually occur earlier in chronologic age. And understanding that mechanism, despite the fact that their viral load is suppressed, is a critical piece that we need to understand. Next slide. Well, I've been pitching the patient-reported outcomes. Let's dig in a little bit here. Let's focus on the figure at the top. So these are the domains that are collected every 4 to 6 months with touchscreens in the clinic. As of this past month, we now have this ability to capture these data at home on a cell phone or on a computer from home for a patient. It's all HIPAA compliant and secured communication. So a patient, historically, when they walked in the clinic, would sit down at a computer, and in less than 10 or 12 minutes, almost for everybody, they would answer a series of questions that assess their antiretroviral adherence, depression, anxiety, their alcohol use, their substance use, their quality of life, their symptom burden, and this is really cool, I'll come back to, body morphology, and their HIV risk behavior. We also have domains for pain. We have domains for inter-partner domestic violence, which has been added recently. But let's dig into a couple of these real quickly. So the symptom burden, I think, is really important because it standardizes how a patient reports the usual symptoms of all symptoms. It's like a review of symptoms, a review of systems that is done routinely before the patient ever sees a provider. And that's beneficial in two ways. One, we know the symptoms, and we can capture that and link it to the emergence of a complication or in association with the emergence of a complication. Another thing that enables me to do as a provider, and I love this, is that I can walk in the door and say, hey, tell me about this chest pain you're having, or, I didn't know that you have fever now, tell me about that. So we can jump right in. It saves the provider a significant amount of time on every routine visit, and therefore the providers actually love this. It also tells us occult issues like depression. A lot of times we pick up depression that otherwise it wasn't there, and a subset of that on every evaluation for depression is an assessment of suicidality. And we pick up across the sites at least 5 to 10 patients who score high on a suicidal assessment that prompts an immediate intervention at the clinic on that visit from one of the psychologists who will come in, or psychiatrists who will have a visit with that person before they leave the clinic. So it's safety, but it's also alerts us to occult suicidal ideation that we might not have, in fact, I'd say it's likely we wouldn't have picked up on a routine visit. So that's another interesting safety aspect. The other two things I'll highlight right here is alcohol use and substance use. And this brings me to perhaps another one of the key, unique, innovative things of Scenics. We can screen for alcohol use disorder, and we do. But we also can initiate an intervention based on the score. And that intervention, we've used brief sort of expert evaluations and have brief interventions with behavioral training that we can randomize. We actually randomize people to routine care or the SBIRT, and that's done in the clinic at the time of a visit. I don't know of any other cohort that's able to do that. And so we can actually do randomized studies at the point of care during a clinic visit. And we've done that for alcohol. Now we've had 2 funded studies to do that. We now have a really innovative study on substance use and opioid disorder that if somebody scores high on their ASSIST assessment, we can then refer them immediately to the study. Of course, there's an informed consent, but after that, they can be randomized to one of 2 different types of interventions. And then you, by definition, when they come back to clinic, you see whether there's improvement or not in their substance use activity. Other things that we are talking about doing in the future is putting in routine assessments of frailty. We have another standardized randomized trial looking at resistance exercise versus aerobic exercise versus neither direct intervention to see how that improves patient function. And that again is randomized into the clinic. Those visits actually, once they enroll, are done outside of the routine clinic visits. So it's a little bit different, but the capture of the patient, the assessments are done during the routine visits, and you look for improvement in all of these factors. So, I mean, obviously I could go on for a while with this, and it's something I think we're all very proud of, but we try to do as much as we can to take advantage of the point of care location and do some innovative things with that. Next slide. The specimens are collected routinely. I will tell you that not every patient elects to allow us to draw the extra 4 to 6 tubes of blood once a year. For those that do, we have longitudinal specimens. I would estimate that somewhere around 40 to 50% of the total population does have longitudinal specimens, so that if you are doing, let's say, a myocardial infarction study, you know the incident date for the MI, you could look at markers of inflammation for a time period before and after the myocardial infarction event to get some sense of this. We've done studies on elite controllers and long-term non-progressors. It's basically open to anyone who wants to access it. And as I mentioned earlier, these samples are stored at the Scenics sites and they're available for use. We can distribute them. We link them to the clinical story. We do that for you. And the only thing you would have to pay for is the shipment from the Scenics site to your lab to access it. And then, of course, you'd have to run your own assays. But this, I'd love to see this used more and more and more and more. So there's viably frozen PBMCs, SNAP frozen PBMCs for genetics. We have a few saliva specimens that I wouldn't tout that too much because there's not enough of them. But plasma and cells are the 2 main ingredients. And we have quality assurance through NIH funded networks that assure that our cell viability and our processes are top notch. Next slide. So how do you use this? Well, you go to the website, which is down at the bottom. It's basically uab.edu/Scenics, but you're going to have this PDF and you can get this. You could also just Google Scenics and you'll get to our page. But the way it would work is that you initially have your idea and you click on a study feasibility form. And it's not required, but maybe you're just thinking, I got this idea. I wonder if Scenics could even do this. Is this possible in Scenics? So that's a quick review that we could say yes or no. And again, we're trying to get to yes. So if you get an answer of no, then it's probably no. but mostly we'll sort of get back to you and say, tell us more. And then in collaboration, you go to the next step, which is a concept proposal. And we almost always link the person who's outside of Scenics with a Scenics collaborator, not to hone in on your study at all, but mostly to make sure that what you're proposing is doable within the Scenics data sets. And that, you might have an idea. We're working on one right now with survivability after a cancer diagnosis. And some of the ideas that the investigator had were great ideas. It's just that we didn't have the data to really provide the assessment that they wanted. And in particular, this goes back because they wanted cause of death. And I just don't think we can in an honest way, tell you what people died from. I can tell you what they died with. I can't tell you what they died from. We will find, for people, especially younger investigators, we will find a mentor. And what's cool about this, think about the sites that are part of CNICS, and then think about the level of expertise and notoriety that these sites have. And we end up pairing younger investigators with world-class, quasi-famous people who spend time with them. And it's a real benefit. And the CNICS investigators love doing it. We, we're judicious about how often we engage them. So it's like doing reviews of papers. You don't want to send a paper to a reviewer every 2 weeks. But we find, without a fail, a really, really good collaborator for the junior investigators, and it's been remarkably successful. And in our renewal, some of the testimonials coming from those folks are just mind-blowing in terms of what they have to say about us and their interaction. The way that once you submit the proposal, it's sent around to 2 CNICS reviewers and a statistician. And then if you hadn't had the feasibility done, the data management core also weighs in on feasibility at that point. And then there's a call that 30 minutes for review between 2:30 and 3:30 Central Time on every second Friday of the month. And again, the way that runs is that the person putting the idea forward will give 5 minutes to present, but everyone's already read the proposal, so you don't have to go into gory detail. And then before the call, we will give written feedback so that the person submitting already knows what the critiques are. And that speeds everything up. So they go, all right, let me go through the things that I see here. Yeah, you brought up this point. Here's how we think we can address it. Or you brought this up and we're kind of stumped. What do you suggest? How would we deal with this? You understand what we're trying to do. And it's a very iterative back and forth, helpful, I think, conversation. Again, we're trying to get to yes. And I'd say 80% of the time at the end of that call, the concept proposal is approved. The other time, the concept proposal might go back for a little bit of revision. And sometimes that revision doesn't require a resubmission or even a review at a conference call. Rarely, every now and then, the whole group wants to see it again. And that's only in situations where there were some major issues raised that needed to be addressed. But again, that next review is positive. It's trying to say, okay, what did you do? Is that right? Is this going to work now? So we try to get to yes. The specimen feasibility request for is easier in a way, because if all you need are specimens from a certain population, you just submit that form and you get a one-on-one consultation with Dr. Jeff Martin at UCSF or one of his team, but it's mostly him. And he will go back and forth and decide what's there with you, whether these are the specimens you really, really want. And it's a very helpful mentoring and consultative service. Next slide. Well, that's it. Took a little longer. I thought I'd go for 30 minutes. I went for about 38. I apologize for going a little over. And I think I'll pause here and take any questions. Thank you for your attention.
Thank you. Yes, just a reminder, you can type and send questions using that questions feature in the dashboard. You probably see that on the right-hand side of your screen. So we're not using the raised hand feature today. So if you have a question, please use that questions panel. And another reminder, we are recording the session, so we'll send you an access link by email once that recording's available. And another note, please also know a webinar survey will automatically launch after the webinar ends. So in an effort for continual improvement, we would like to hear your thoughts. So please provide feedback by clicking the survey link at the end of the webinar when we get there. So meanwhile, let's take a look here. Questions. There's one here that says, do you have any link to non-HIV infected cohorts?
We do not have a formal link. We used to work with the MESA group and link up, but I have spoken to different aging groups, And it's relatively easy to link up with other existing data sets because you just have to map what outcomes you're looking for and just pair them up. So there's also, through Scenics, there's an R24 that just got renewed that now Heidi Crane is running, and Kevin High had run it before. And it is a link between the National Institutes of Aging and the National Institutes of Allergy and Infectious Diseases to allow joint projects, pilot projects, seminars, and that type of thing that are focused specifically on HIV and aging. And that would be a great group to work with you in trying to identify the National Institutes of Aging cohorts. And it would link up, I think, very nicely. So that would be a really great opportunity to look at outcomes of people as they age with and without HIV infection.
Great. And then a question about data here. You said this cohort is available to any researcher. What limitations are there to accessing data?
Generally speaking, there's not much. The main thing we're looking for, well, one thing is that you'd have to sign an agreement that says you're not going to use the data for anything other than what your approved concept was for. So we don't want side use of the data set for other things without permission. So if you had a data set, you say, I've got another question or two I want to ask, that's no problem. Just let us know about it. What we don't want to see happening is that publications or other presentations are coming out of a data set that we gave for one purpose and it's being used for another. It's mostly just control of knowing what our outcomes are, but it's also, I think, just a courtesy to us that if you get the data that you use it for what it was intended. And the second thing is what we're going to be doing in the review, I didn't say this earlier, but if you have, when you submit a concept proposal, in addition to feasibility, we're also looking to see if somebody else has either done that work or is in the process of doing it now. So we don't want two independent groups studying more or less the exact same question. The way we deal with that is twofold. One, oftentimes we'll get the new proposing person in touch with the group that's already going, and 9 times out of 10 that works into a joint project and they end up working together, which is great. The other thing is that we can sort of change the questions just a little bit so that the new project is augmenting or creating some degree of hopefully synergy with the study that the other group is doing. So that's the way we kind of help modify and moderate things so that people aren't competing with one another within the network.
That's great. Another question around data. Is there any ECG or autonomic data available?
There will be ECG data through the atrial fibrillation project that's now underway with Adjudication. I'm not aware of any autonomic or any other types of specific neurologic data. That said, a lot of people, when they submit an R01, you can submit a concept proposal, say what you want the sites to do, and then in the process of your R01, you have funding that helps cover the cost of collection of new data elements that we don't currently have. And that's how a lot of our data set has grown over the years. Like, for example, the genetics started off that way. And again, the adjudicated MIs ended up coming from an R01 type grant. So don't be shy about asking for things that that you'd like to see Scenics do, even if we don't have it now. We will give you an upfront, honest answer. Occasionally, we say, nope, that's too onerous. We can't ask the sites to do that, or they don't have capacity to pull that off. But there's no harm in asking. If you have an idea that you're really interested in, send it in.
Good. Once you have been awarded access, is there a limited time in which you have to use the data set?
Not really, but of course we'd like this to move along kind of quickly. I think the times when we've seen delays is when the investigator submits a concept proposal. We like to have it about 4 months before an R01 is submitted. If you want a letter of support for the R01 saying you're working with CNICS, you got to think about that a little bit early. What doesn't work out well for us is if we get 2 weeks before the grant's due, oh, can you give us a letter of support to work with CNICS? It's almost impossible to be able to judge that. We sometimes write these kind of what I consider Midland letters that say we have intent to review this, and it doesn't help. But the situation where it's done the right way, concept proposal is submitted, it's approved, get a letter of support, the grant goes in, then sometimes the investigators need to wait for the funding to happen before they can actually have the resources to do their analysis. So that would be that's the most common cause of a delay. But typically we want it to be done within ideally a year. 2 years would be a stretch, but I think most people get their work done pretty well and pretty quickly.
Thank you. All right, and here's one. Would you please comment on frailty or other performance measures for the HIV cohort?
Yeah, so we're just now entering into that realm. I mentioned earlier that we have this randomized trial. The things that we're going to be looking to incorporate are routine assessment of sit-stand, grip strength, and a modified timed walk that can all be done at the time that vital signs will be taken when patients enter the clinic. It won't be done obviously every visit, but it might be done annually. We have to think about the eligibility. We're leaning towards anybody 50 years of age or older, and we would do that annually. So that's some degree of performance. The second thing we're now in the midst of trying to work out, and will be probably incorporated within 6 months or so, is working with the UCSF group to do a routine brief cognitive function assessment on a computerized system. I know there's a lot of commercial companies that have those programs. We shied away from purchasing that out of concerns of 2 reasons. One is what happens if the company goes out of business or gets bought out by another company that isn't as friendly towards sharing data back with us. That was one concern. And the second is that we don't know over time whether they might increase the price for their product. And once we're committed to using it, we're a little bit worried that we could get held out over a barrel for data that's very important. So there's some investigators at UCSF who independently have done this, and we're in conversations with them because it's, as my understanding is that the development of this was funded by NIH, and therefore will be available for use by other NIH-funded entities. And so that's how we're going to move forward with that. But I think in the next 6 to 12 months, we will have cognitive assessments available. It should be helpful.
Great. So before I ask for your closing comments, or maybe this last question is a good closer. Oh, that was a nice sound effect too for the last nearing the end of our program. How do I go about specifically getting started if I have a question about whether CNICS will fit the needs that I have?
I would start with a visit to the website and just kind of scan it out. And then there's a contact us button, and I would just use that, and we'll get right back to you. We got a team who monitor that, and that would be the best way to do that.
Wonderful.
Or you can just reach out to me. Yeah.
Sorry, go ahead.
No, I was just going to say you could reach out to me directly if you wanted to as well. or any of the investigators within CNICS. But the website's probably the most organized way, because then we track the request and can follow up with you more assuredly.
Indeed. Well, thank you again so very much, Dr. Saag. It's been a real pleasure learning about CFAR CNICS. I got the lingo down now. And thank you to everyone for participating. This will be the end of our program.